Hi, the topic is outbreak investigation. Of course, I understand that I can see more than 80 participants, and I'm sure that many of you are actually doing outbreak investigations in the field. And truly speaking, at NI, we not only take at least half a day class for outbreak investigations, but also the scholars used to go to field like district officers or other medical officers. They go to the field and they do it, and then how we learn it. So in 45 minutes, what I'm going to do is I will talk about the approach towards outbreak investigation. We have 10 steps, and outbreak investigation is not done by only one person. It is a team who works against it, and we have different roles assigned for all the team members. So it's a collective approach. And of course, the district or the state government have some policy. I'm not sure again whether IHIP platform is introduced in your state, that is Integrated Health Initiative platform. If it is, somebody can respond whether IHIP is already there in place or still IDSP is going on. Anyone can please tell me? I'm sorry if I'm not audible or not clear. I'm again repeating, is like whether IDSP, that is integrated disease surveillance project, is still going on to detect outbreaks, or we have now newly introduced something called IHIP, Integrated Health Initiative platform. Is it introduced in Odisha?
Yes, sir.
Hello, good afternoon. Sir, I'm a many consultant from state and BBDCP Odisha.
Okay.
IHIP has already introduced in the state and we are reporting on IHIP, but it is not the exclusive reporting system, not yet made full-fledged.
Right.
We are still relying, but side by side we are doing IHIP. As long as it gets streamlined in the state, we will be doing it. And we have a module on outbreak reporting on IHIP.
Excellent, Dr. Mishra. Thank you. So, okay. So based on that, today's main objective of this session is introducing you so that like the approach, so that with the help of the existing system, you utilize those resources, and then you do not fear to report an outbreak, and you do investigate as a team and then try to learn more. Of course, we do learn every time we do an outbreak investigations, because it's not like a 1 + 1 2. It is like when we go, we reach, and we learn something new. So so with that note, let's start. I have divided into 25 minutes to half an hour like my presentation with a description, with a case. I have given an example, a case study, very small one. With that, we will see how the 10 step goes. And the second thing is, after finishing that, if you have a question, I'm happy to discuss. All right. So hope my slide is visible. We will go on now. The key areas what I thought I will put is like preparing yourself. You know that we all have to be prepared for an outbreak. Outbreak doesn't come by saying or intimating to us, so we have to be ready always. We should know how to analyze the outbreak, at least the counts, and based on that counts, we often generate hypothesis in terms of what caused the disease or the outbreak, and how it happened, so that we can prevent it in future. So we do test this hypothesis through higher level studies, and then finally we implement our control measures, which are region specific or culturally accepted, economic, like that. All right. And to get ready to investigate an outbreak, we of course know that we need some resource in terms of money, in terms of health personnel, or manpower, if you say. And then we have some equipments in our hand. We should have always, for example, you have to have a mobile phone. For that you need a SIM card, so that you can communicate appropriately. And we have to have our team established in such a way that we quickly do our data collection, we quickly go and investigate, we go and treat the patients, and finally we have other things like a laptop and other gadgets if required. Those are very important, and internet connectivity as well. All right, this is nothing new to you again. So I have written here the steps of outbreak investigations. Now, if you see carefully, just one moment. Yeah. So the first four steps uh, up to here, even when you hear from the field that one village has reported something, you can actually start initiation of this processes 1, 2, 3, 4, determine whether the existence of an outbreak is there, you confirm the diagnosis, define and search for the cases. This you can at least initiate being at the district level itself. Those who are working at the field level can actually initiate these things, and I will come one by one, of course. So that means when something is required, it is not like first we have to reach to that place to start our 10 step of outbreak investigation. We can initiate wherever we are and we start doing that. Then comes the question of generation of hypothesis, how it happened, which organism caused, and all those things. That we once we reach there, we initiate based on our previous findings, which we often called as descriptive finding. The first four is descriptive finding, and then we generate our hypothesis. Followed by that, number 6, we do some analytical study to test our hypothesis, and then we draw conclusion, we report, we implement our preventive measures to control it. All right, with that note, let's move. I have given us very small case study to you. It's very simple. I have written here an outbreak of diarrheal disease was reported to you by the healthcare worker of a village. She reported that there were 8 cases of diarrhea. Few of them had gone to the local quack. Others did not do anything. If you look at it carefully, the, the very important part of our team, the healthcare workers, they are reporting on something. That is the diarrhea cases, but again, it is only diarrhea. They do not know what is the definition of diarrhea. So they have limitations in their information. Even they have limited information in terms of they know 8 cases, but he or she says that only few of them had gone to the local quacks. Now please remember, this few is deliberately kept here. When epidemiology point of view we talk, or the investigation point of view, we require numbers. So it is incomplete here. Few of them had gone. How many of them have gone, we do not know. And the challenges also you can see in terms of local quacks, they have gone there. The question is why this it's not about just local quacks or not seeking treatment or anything. It is like our healthcare system is not only for preventing or investigating outbreaks. At the same time, we are also treating those who are affected, those who are diseased. So we have to save them, and that is the priority at the beginning. So what we will do, if you see this is a village, you need a map always in your hand. Even if it is incomplete, it may not be that structured, that's fine. But if you understand the map of an area, that is the first thing you should have in your hand. Whether you keep it in PHC, you keep it in district level, that is fine. But if you have it, you have a good clarity. For example, from PHC, is there any medical facility available? You immediately start mobilizing your patients there, and you take care of other things like initiation of other investigation steps and all. That is fine. I will come back to this map once again. Now the question is, when you get some information in front of you, you have many questions in your hand, like in your mind, not hand exactly. And what are those? The first question, is it an outbreak event? Somebody is reporting only 8 cases. What shall I do? If it is, so the thing is, immediately we start analyzing actually within our mind. The question is it diarrhea means what? Diarrhea can cause many diseases. We have many differential diagnoses. So what exactly it is? And then whole lot of questions you have. Who are suffering? How did it happen? Shall I investigate based on just this finding? Even, well, as I said always to you, I mean, right from the beginning, that is the first thing. What you do is like, yes, we investigate. How to investigate, we will see. The first thing you do is treatment initiation. That is the foremost thing. We can't afford single individual dying just because of diarrhea, at least at this present days. However, it is not just diarrhea. There are many symptoms. So sometimes even unknown fever, and recently again Nipah outbreak took place. So we are always concerned about what is the diagnosis. First thing you do is you mobilize your resources. It's a team approach again and again. So there are physicians, there are PhD medical officer, you have healthcare workers, you have ASHA. Mobilize depending upon the severity. You mobilize at the same time, protect them. For example, if it is a unknown fever instead of diarrheal illness, do you think just like that we can move and they can go and interact with the patient? Of course not. High fatality can be there because of any Nipah virus infection or some other unknown fever. So prepare for that at the same time. That happens not within this initial step, but that should be prepared beforehand from the state level. All right, and then also at the same time you start case finding. You mobilize your village level healthcare workers or other stuff, and then try getting the information more on case finding, because 8 cases initial reporting, it may not be 8. By that time you are inquiring, it has gone to somewhere in 15. You never know. All right, the first 4 steps, that is determining the existence of an outbreak, a big question whether really we can call it an outbreak. Now at least if we do not know statistical formula and all those things, sometimes we call more than 2 standard deviation of the expected cases. Now you being in a practical field, you know what is the what are the difficulties. Who will calculate the 2 standard deviation at that point of time? Rather, you know your area and you expect, suppose in winter season somewhere in December, you get 8 number of cases in a single village where only some 1,000 population is there. Do you think it's usual? Of course, it is not usual. It is not a rainy season when you have more number of diarrhea cases. So you know at a glance, hey, this is not possible. Something is wrong. So start initiation of your investigation, confirming your diagnosis. So you are mobilizing at the same time to your team. I'm sorry, I'm getting an important call. Can I get back to you within 10 to 20 seconds? I'm very sorry. Just a moment. Yes. So now the second step is confirming the diagnosis by lab investigations. May or may not be. Again, suppose for example, it is evident from your clinical diagnosis, why you should go for lab diagnosis. Plus, lab diagnosis is often not really possible for all the case patients. So in that case, we take sometimes the sample, for example 5 samples or so, and we send it to the laboratory wherever it is possible and feasible. Now the question is, shall we wait for the lab investigation to confirm our diagnosis? No. So we have to have a definition of a case and the possible diagnosis based on some other definition. For example, IDSP definition. We have all the like major outbreak related diseases, and the definitions, the working definitions are given. Sometimes even if that is not available in your hand, you can have your own working definition. Followed by that, once you have a case definition, which is very important, you now look for the cases. The team goes for looking at the cases. It is just line listing of the cases, which house and what are the minimum variables you may know. For example, name, age, gender, and the case definition is meeting or not. The most important thing, so that we understand the household members. It is not just identifying that whether you have a such case in your house or not. It is like whether you have or not. At the same time, who all are you, at least. So that then you know the whole area, as well as you have your denominator in your hand, that how many people are there and how many are actually affected. So we always need that numerator and denominator. Numerator is your cases, number of cases affected, and your denominator is your total population. And this total population may not be always like what are the total population of that village. Sometimes which population is affected, based on that also we may calculate. For example, under 5 children. If the cases are only under 5 kids, for example, measles, if it is only you are looking for under 5 kids with measles, then why you should go for all the population? You take the information from under 5 kids only. And the other big question is whether the health system should go to the community or the community should come to the health system. That is active versus passive surveillance. Sometimes the best idea is you mobilize the resource and do an active surveillance, because then you know the appropriate denominator. Whereas passive surveillance may not give you the appropriate denominator. uh, Apart from that, your number of cases also you can miss. Somebody may die, somebody may not come to you, there are a whole lot of problems. So active surveillance is the best. So this gives you the overall first few steps, often overlapping with each other. It is not 1 2 3 4, it is all together 1 2 3 4 all together is going on. I'm not taking any questions at the moment. I'm very sorry because of our limitation. Let me finish my slides and I'm again happy to take questions. If you have any, you can just take a note of that and we will see. The question is then what? Already I told you that you are actually counting the cases. The counting is so important. And what is the distribution? Who all are affected? You are line listing your cases always. And this line listing should be uniform. Your different healthcare workers are going, or the data collectors are going, and it may not be always possible to take a similar kind of data, but as much as possible we should gather a same information when we have our different formats in our hand. For example, IDSP format, or now even in your tablet through IHIP platform, we have standardized template. So no question of using any other things. Now, suppose your total population is 5,000 and you see your male is 2,700, female 2,300 in that village, and number of cases total is 30, male 20, female 10. This much of information you got. Now the question is, with this information, what we will do? And one more thing, please remember that now when the investigation started, you are getting 30 number of cases. This 30 actually may increase slowly or rapidly. We do not know. But at least for the first initial investigation, this is the idea that we got. That this is only for our hypothesis generation, nothing else. So what we will do is we will do some descriptive statistics out of it. And descriptive statistics, when we say, that is in relation to time, place and person. Now time gives what? Time says what is the nature of the disease. For example, if you see that the cluster of cases within say 30 hours of the first case, then you know that that means something really acute onset, a point source, maybe some temple, they gone somewhere in a temple or a festival or any marriage ceremony or anything, and there they took food, and that may have caused such things. So such information also we have to collect at the same time, other than the case findings and line listing. Now the other thing is potential agents. For example, again, if we see that within 30 hours everything is happening, then we can think of those illnesses which have a very shorter incubation period. For example, cholera, for example, again, bacillus cereus infection. So I'm not going into that. I'm not a microbiology person, so let's not go into that. So your team also have microbiologists and epidemiologists, and they understand that what is the meaning of this median incubation period, and what could be the possible organism at the same time during line listing. Possibly the microbiologist or someone from lab has been mobilized and has taken the sample, and they have sent it for confirmation. Now the second thing is place distribution. We will see in our next slide that what exactly it means. The meaning is like, suppose if I say the temple has caused, then if you see the distribution of the cases, suppose all the cases are around the temple, then you know that okay, possibly this is giving me an idea that it is near to that temple, and possibly temple is the source of that infection, or the prasadam what we are eating, that could be the potential source. So that is an example. Again, the person distribution, and this person distribution says us that who are affected people. Is it under 5 kids? It is only those who are elderly. Only fever is happening to the middle-aged people, and then we again get more idea about the person affected and whom to investigate, whom not to investigate, because we have limited resource. And finally, what we do is like we calculate the attack rate. It is very simple. It is how many person got the disease, and within that period, how many were the population in that age or gender group, or whatever your population is. Population again may or may not be the whole village population or the geographical region. It can be a subset of that population as well. So if you get that, so per 1,000 population, or per 100 population, or per lakh population, how many are affected? It is a simple attack rate and nothing more than that, to understand which age, gender, or population group is actually having more disease and are at risk. That is important in terms of your prevention point of view, as well as not only treatment. So I have given you a kind of sample uh, epidemic curve. This is what we have done is like, this is day distribution in days, and this is the number of cases in the y-axis. This distribution, this can be, instead of day, can be even in hours, when the disease is very acute. And I hope like everybody in this team knows, when we have seen so many COVID related curves in like last 1 year. So you are familiar with it. I'm sure district epidemiologists are there, and they will be able to prepare. This can be done even in our Excel sheet. This is a place distribution, smart mapping. Here, what I have done is like how the cases are distributed. Uh, like for example, this house has 2 cases. This house has 2 cases. Here, 3 cases, like that. And if you see clearly, here field and a pond, nobody lives there around. Fine. Here there is a market, and here there is another point, possibly the only drinking source for these houses. They have more number of cases, and here also around this pond on the other side is some more number of cases. But if you moves out from that place, they have another tube oil, which is given as a red triangle. It's like they are not, mostly not affected. So possibly they are taking the water from this source, and these people around here are possibly taking water from this source, I mean this pond. And there is a market also, high chance of contamination. So possibly this is giving me an hypothesis that possibly this is the source of this uh, infection. And finally, the person distribution. I think already I talked about it. You have the number of cases. Again, you have the total population in your hand, or a subset of population, and then you compare the incidence or the attack rate in different groups. All right. Now, this is just a template kind of how we express attack rate in different age or gender group, or different subgroups. And you can see, for example, the first group, that is 0 to 4 year age group, is a high attack rate for measles. And then you see the gender is not differing much, only 4.6 and 5.2. So this is how we present and we understand who are affected more. So with this time, place, person distribution, now you come to a hypothesis that, okay, possibly the pond water, usage of pond water as drinking water source is possibly the cause or the source of this infection. And seeing the epidemic curve nature, we are still waiting for the lab results, but we feel that this could be Vibrio cholerae. So by that time, those who have gone to even the clinical features are also suggestive of what could be the possible organism. For example, rice watery, like watery stool, and then you know that possibly this is a Vibrio cholerae infection, and you start with your doxycycline loading dose. You give whatever other treatment, fluid, and you manage them. So, but we cannot just say possibly this. That is the minimum thing, but the best idea is we also test our hypothesis that yes, this is the source of our infection, or this is the causative organism. What we do for that, we do a higher level study. For example, analytical study, like cross section, either a case control study, those who are affected and those who are not affected, you are going to them and you are asking them whether you were exposed to these factors, and you come out with some more estimate like odds ratio, or if you are doing a cohort study, you come with relative risk, like that, to understand that yes, my hypothesis is absolutely correct. So interpretation, as I said, like when you do such kind of analysis, you say that, okay, for example, usage of pond water versus as drinking water versus no use of pond water as drinking water. What is the odds ratio coming? And you are, suppose your odds ratio is 5, and you say that yes, there is a high odds ratio and possibly 5 times higher risk of developing cholera if someone uses the pond water. So like that, and again, don't like at this session, because it is only 45-minute session, we are not, let's not go and break our head on this analytical study designs. Again, I am saying, I'm sure that district epidemiologists are there, so the part, leave it on them that they analyze it. All right. So exactly what I have given to you, how we calculate here relative risk we have given, and for different exposure. For example, we feel like foods has caused it, and what are the foods? When you are doing your line listing or later analytical study design, you enlist all those foods, common foods, what they eat, and you find finally that raw custard is possibly having a high risk of causing the disease or the outbreak. And we also calculate the attribute fraction from it. And again, I am requesting to leave it on our district epidemiologist because our time limitation. The once this is over, and possibly by that time we have got our results also, say for example, if it is a vibrio cholerae, we know that hanging drop preparation also we can do, we can also culture, and by that time in another 2-3 days your results are available. And sometimes it takes time, but that's okay, we understand what happened. And so the question is again 7 to 10. If you see the various steps, one is you draw your conclusion and compare with the similar facts. That is fine, that okay, possibly usage of this thing, suppose pond water has caused the disease, and so what? That is the question. Your conclusion is fine, and possibly you will also communicate to your higher officials, you report whether it is writing or it is app based, or it is through your verbal communication, everything is fine. But the question is, uh, what? So what? The whole idea is treatment of your outbreak and affected people. That is the first thing I from the beginning I have said. The second thing is control measures, so that it doesn't appear again in near future. Now the question is, the biggest question is like, think about that village, what I have shown to you. Usage of pond water caused the disease and possibly contaminated from market water. Do you think we should close the market? And second thing, we should stop people using that pond water. How it will be socially accepted when you do not have alternate facility in your hand? So then we have to think very carefully and suggest such a measure which is acceptable, which is feasible, which is cost effective in that way. For example, if at the moment if I say to you that okay, teach people how to disinfect the water, for example, boil the water before you drink, or before you cook you wash your hands well with soap and water, because it is you people who are actually facing the such burden. Some people even may come up with you that we are so poor that we cannot wash our hands with soap, and that is not our practice, especially in the village. It is not a practice. Sometimes they are even going for open defecation and using the same pond for washing. So there are practical problems, and we have to take a decision which is not taken in the sitting in the office, that those who are working in that village, those who are known to that social culture, and in that area, they are familiar with the various social cultures, and what could be the most acceptable or feasible way to suggest a control measure. All right. The other thing, most important thing, when we take a control measure, it is not just stop there. We suggest something, and we know that this village is very much prone to develop this disease, or this geographic area is prone to develop this disease. So whatever measures we have taken, we should also follow up to get a better result and sustain with that preventive measures. Even our preventive measures may not work sometime, so then we have to revise it, that how we can make it better, and if it is working good, how we can continue with that one. The final thing possibly I will say to you is, like, see, this kind of outbreak investigations, when we do, of course, this is an emergency, we all understand that. And with this emergency situation, we often forget to go with ethical standards. For example, if I know that something happened to one person, and then the information what we collect, it is with name, without like anonymizing it, we are disseminating such information, and which village it happened, if we are disclosing all such things, that is not accepted from our end. We have to protect their dignity, their ethical rights, and everything, and their confidentiality. So with that note, uh, only one thing I will tell you, that if uh, if you next time, if you come across with an outbreak or possible outbreak, my sincere suggestion to you is, like, do not hesitate to investigate. Sometimes we have seen that there is a tendency to hide it. Hiding, you may do that. If it is controlled, you hide it, but control is fine. But if you hide it and then it is not controlled, then it can lead to a massive thing. So I'm sure you all know about the Kerala Nipah virus case. So whenever if you feel there is an outbreak, please investigate. Make your own team from districts, and you have your templates in your hand. Whatever instructed through IDSP or IHIP, you be ready with that. Even if something mistake you do, in terms of, I do not understand that, that is also fine. Never stop there. Investigate. There is a team, so I am sure that everybody can take the make up the small mistakes, and so that you can actually help the community. Okay, so all right, thanks for listening. Have a great day.